Good evening, friends. This is a case of sarcoidosis. This young patient has come to us with complaints of fever, night sweats, dry eyes. On labs, we have a normocytic anemia. We are having a slightly raised ESR, and along with it, we are also having slightly deranged liver function tests. So, what is basically sarcoidosis? Sarcoidosis is a multi-system granulomatous disease of unknown etiology. In fact, we keep saying that it is one of the diagnosis of exclusion that we should make whenever we are trying to see a patient. The closest differential to such a patient who is coming to us, a young patient, a woman in her mid-40s, usually coming to us in India with fever, severe fatigue, breathlessness, joint pains, it should warrant us towards thinking towards the national disease of India, that is tuberculosis. But one of the major differentiating features that differs sarcoidosis from tuberculosis is actually the presence of a caseating granulomatous disorder in tuberculosis versus a non-caseating granuloma in case of sarcoidosis. The other parts of the granuloma, however, are very, very similar, with a collar of lymphocytes, macrophages, epithelioid cells which fuse together to form multinuclear giant cells. All of these are very, very common, both in cases of TB and sarcoid, but the presence of caseous necrosis is what differentiates TB from sarcoidosis. When we talk of pulmonary involvement, we usually talk of the scadding staging, and we have 4 stages in it. Stage 0 is basically a normal chest radiograph. Stage 1 is the presence of bilateral hilar lymphadenopathy. Stage 2 is the presence of bilateral hilar lymphadenopathy with diffuse interstitial infiltrates. In stage 3, these infiltrates start getting more and more dense throughout both the lung architectures. And in stage 4, these infiltrates will coalesce together and form fibrotic nodules, which leads to a fibrotic lung, thereby leading to the picture of a restrictive lung disease on the spirometry. So lung function tests in the later stages may resemble a pattern which is very, very similar to interstitial lung disease, ILD as we commonly call it, with a restrictive pattern. For stage 0 and stage 1 patients, usually you do not require any treatment. Treatment is required for patients progressing beyond stage 1, that is stage 2 and beyond, or in patients with ocular sarcoid. When I talk of ocular sarcoid, what are the manifestations that are seen in the ocular involvement of sarcoidosis? We can have a variety of atypical presentations ranging from anterior uveitis to conjunctivitis to keratoconjunctivitis sicca, like a Sjogren syndrome-like picture where we have a dry eyes-like picture due to hypofunctioning of the lacrimal gland. A varied presentation can be present. But ocular symptoms of sarcoid warrant treatment, and treatment should be initiated with steroids. 0.5 mg per kg, usually prednisolone is what we start off with. We keep the patient monitored for the presence of other symptoms or deterioration of lung function with time. We do repeated spirometries. Monthly visits are warranted both at the ophthalmology centers, at the rheumatology centers, at the pulmonology centers. And what we are usually trying to do is we try to continue the treatment for 6 to 24 months. And upon a good amount of remission that we see with our treatment, that is when we are trying to gradually withdraw the steroids or maybe taper the steroids. And we can also take the help of steroid-sparing agents like methotrexate, and you can often use drugs like azathioprine as well. So apart from the pulmonary manifestations and the ocular manifestations, you can also have certain other presentations, like you can have the skin manifestations of sarcoidosis, which comes in the form of lupus pernio, and the name lupus pernio in itself is a misnomer. Pernio means purple, however these lesions are not purple in sarcoidosis, they are red crusty lesions, and lupus is usually referring to a subtype of diseases which are commonly called the systemic lupus erythematosus or SLE. However, as we can clearly see, these are lesions that are found in sarcoid and not SLE. So the absence of SLE, that makes it lupus, that makes the word lupus a misnomer, and the absence of purple lesions, that is pernio, makes the word pernio a misnomer again. You can have a finding called erythema nodosum, which can be basically found usually on the shins, but again, it is not specific to the shins. They are red paniculitic lesions, that is inflammation of the underlying fat in the skin. And what usually happens is there's a combination of fever, arthralgia, and erythema nodosum, commonly known as the Lofgren syndrome. So Lofgren, Lofgre, and the F here is meaning fever, and En means the erythema nodosum type of lesions. You can also have a uveo-parotid involvement. I mean, there's a combination of uveitis. You can have parotid involvement as well. Parotid enlargement can be seen along with fever, which causes something which is called a Hereford syndrome. That is HEREFORDT. That's Hereford syndrome, which is uveo-parotid fever. The joint involvement, as I commonly said, is consisting of all symptoms like arthralgias and arthritis. And yeah, one more thing. Serum ACE levels have been talked of in details in theoretical contexts, but serum ACE is a really poor marker to diagnose or monitor, even as a prognostic marker or a diagnostic marker in sarcoid. It is one of the most less efficient markers because it can remain high in tuberculosis, it can remain high in silicosis, it can remain high in lymphomas, and even in 75% of patients with untreated sarcoid, you can have the presence of a high serum ACE levels. There might be 80% cases where you might find a tuberculin skin testing to be negative, which again rules out tuberculosis. But please consider the presence of anergy in immunocompromised patients or HIV or patients fairly severely immunocompromised like HIV, because you can find a cross reactivity with TB in these cases. So do not rely on tuberculin skin testing. Rather, the investigation of choice should always be a transbronchial biopsy or an endobronchial biopsy. And that biopsy specimen the specimen should be sent for a bowel culture, where you will find the CD4 to CD8 ratio being reversed, and along with it, you will find the presence of non-caseating granulomas, as I already talked of. 24-hour urine calcium levels are usually high in sarcoidosis, which actually is one of the major causes of polyuria. So there are so many doubts regarding why polyuria has occurred in this patient. You clearly find that in sarcoid, there's a huge production of the enzyme 1-alpha hydroxylase present in kidney. So this enzyme usually is the enzyme that activates vitamin D in the kidney. And the macrophages that are present in sarcoidosis produce this enzyme 1-alpha hydroxylase in large numbers, leading to a lot of vitamin D levels. A lot of serum calcium is absorbed from the blood and the gut, thereby leading to hypercalcemia. It is this hypercalcemia which predisposes to hypercalciuria. And this hypercalciuria is what in turn leads to the formation of number 1, renal stones, or number 2, it leads to the formation of something which is called a renal or a nephrogenic diabetes insipidus. That is one of the causes of polyuria in these patients. 2% cases may also present with central or cranial diabetes insipidus, but again, that is something which is very rare. I've usually talked of all the other manifestations of sarcoidosis, and that should be it for this case. The closest differential again being tuberculosis. So in a country like India, always rule out the other systemic manifestations, the other systemic disorders. It should usually be an interdisciplinary approach treatment, where the dermatologist, the ophthalmologist, the rheumatologist, and the pulmonologist, all 4 of them, depending on what the symptoms and what the presentations of this patient are, they all come together and they formulate a plan for monitoring, both for the diagnostic as well as for the prognostic markers of these patients. Thank you for patient hearing.